Hello and welcome to part 4 of clinical cases for the endocrine block. Today we're going to be taking a look at what happens when the levels of calcium in the blood go wrong. We're also going to be taking a look at an imbalance of vitamin D and the effects of that. Following that, we'll take a look at acromegaly, hyperprolactinemias and diabetes insipidus, and then we'll finish off with abnormalities of sexual differentiation, including XY dysgenesis and hypogonadism for both males and females. But let's start by taking a look at what happens when the levels of calcium in the blood go wrong. So hypercalcemia is a state of having too much calcium within the blood. At first, this can have no symptoms whatsoever if it develops in a mild form, but more rapid onset leads to a greater level of symptoms. And having said that, the clinical features are actually fairly non-specific. They range from things such as lethargy and generalized aches to constipation and psychosis, kidney failure and bradycardia. Fairly non-specific, and if a patient presented with these symptoms, you wouldn't immediately think hypercalcemia. And therefore we need to check the levels of calcium, and we can do this in two ways. We can check our total calcium, which should be between 2.2 and 2.6 millimoles, and this measures all our unbound and our bound calcium in the body. Alternatively, we can measure just our ionized calcium, i.e. just our unbound calcium only, and this should be between 1.1 and 1.3 millimoles. So values outside this range, higher than this range, would be hypercalcemia. And to treat this, what we would need to do is give oral fluids, IV normal saline, anti-resorbatives such as IV bisphosphonates, and if the patient is on any medications that would raise their calcium levels, we'd need to stop these as well. With hypercalcemia, it's really important to differentiate between whether it's PTH dependent or PTH independent. So for this, you need to understand how we regulate calcium levels in the body. And it's important to recognise the roles of PTH and calcitonin as hormones in the ways that they increase or decrease calcium levels in the body. So PTH dependent hypercalcemia, the most common causes behind this are primary hyperthyroidism, tertiary hyperparathyroidism, and familial hypercalciuric hypercalcemia. In terms of PTH independent hypercalcemia, in other words, the calcium is high regardless of what our PTH is doing. This is normally linked to malignancy. And humoral hypercalcemia of malignancy makes up 80% of cases, and it's commonly a squamous carcinoma and has a poor prognosis. This can also occur as a result of skeletal metastases. So just remember that your calcium is really important in the body, and 99% of it is stored in the bone, whilst 1% is found in the intracellular aspect of the body, and 0.1% is found extracellularly, in other words, ionized or protein bound. So also we need to think about hypocalcemia, so this is the reverse, this is not enough calcium in the body, so less than 2.1 millimoles of total calcium. This presents in exactly the same way, i.e. mild low levels will result in asymptomatic or very few symptoms in the patient, and a rapid onset will cause a greater level of symptoms. Again, the symptoms are fairly non-specific, and they are usually related to the neuromuscular excitability levels. So it usually causes things such as paresthesia, carpopedal spasms, laryngospasms causing stridor, or bronchospasms causing a wheeze. And the causes behind hypocalcemia predominantly are sepsis, hypomagnesemia, so not enough magnesium in the body, hypoparathyroidism, so again not enough PTH this time, and vitamin D deficiencies. So sepsis can cause hypocalcemia because sepsis increases the level of cytokines in the body, and as a result reduces PTH gland activity. If we've got reduced PTH activity, this can lead to lower calcium levels in the body. Hypomagnesemia, so this is low levels of magnesium. This only affects around 10% of hospitalised patients, but if you think about it, actually that's quite a large proportion of patients. And a low serum magnesium causes impairment of PTH secretion and also resistance of the end organ to that PTH. As a result, this can lead to low levels of calcium as well. It's also important to be aware of hypoparathyroidism as a cause of hypocalcemia. So remember, for hypercalcemia, we talked about primary hyperparathyroidism, but now we're thinking about hypoparathyroidism, as a cause of hypocalcemia. In terms of management of hypocalcemia, we need to get those calcium levels back up. So it depends whether the patient is not producing enough PTH or whether they're resistant to PTH in the ways in which we'll go about treating this. Next we have vitamin D deficiency. So the pathway of regulating vitamin D is really important. So vitamin D enters our bodies in an inactive form. This is cholecalciferol. It's inactive, and we get this from fish, milk, egg, and also from sunlight. It undergoes a variety of processes in order to become the active form, which is calcitriol, which is eventually formed in the kidneys. It's important to know this step and where things can go wrong to cause a vitamin D deficiency. So vitamin D deficiencies can occur as a result of the patient not getting enough vitamin D, i.e. they don't see enough sunlight, they don't have enough vitamin D in their diet. And consequences of having this deficiency, in children this can cause rickets, and in adults this can cause osteomalacia, and this is soft and misshapen bones. In other words, the main effects of vitamin D deficiency occur an effect of bones. It leads to frequent sickness and infection, fatigue and tiredness, and predominantly bone and back pain. The risk factors for developing vitamin D deficiency include having darker skin, being elderly or overweight, not eating much of those key vitamin D sources in the diet, or living in a location with very little sun. So treatment for this condition should focus on the underlying pathophysiology as to why vitamin D is deficient as opposed to actually replacing it. Acromegaly is a hormonal disorder this time, so this is where the pituitary gland produces too much growth hormone during adulthood. And what's really important about that phrase is it's too much growth hormone during adulthood. So too much growth hormone in childhood leads to gigantism, and too much growth hormone in adults lead to acromegaly. And this leads, so it's a slowly progressive condition, and this leads to enlarged hands and feet. So the patient will often explain how their wedding ring no longer fits on their finger, or how they have gone up several shoe sizes in the past few months despite being a fully grown adult. They may also notice changes to the shape of their face and skin tags as well as impaired vision, headaches and limited mobility, but this can occur as a result of other factors. So the causes of acromegaly could be a pituitary tumour, for example a pituitary adenoma, which is non-cancerous and secretes excessive growth hormone, causing pretty much all of the symptoms we've just discussed. Alternatively, you can have a non-pituitary tumour which still secretes growth hormone. These tumours are located in different parts of the body, including the lungs, the pancreas and the adrenal glands, but either way they're producing that growth hormone which is causing this acromegaly. It's really important to be aware of this condition because it can lead to several complications, predominantly hypertension, cardiomyopathy, goiter and diabetes. Next we have hyperprolactinemia. So this is the presence of abnormally high levels of prolactin in the blood. So normally prolactin levels are less than 500 in women and less than 450 in men. So prolactin is released by the anterior pituitary gland, and it's predominantly associated with lactation and breast development during pregnancy. The symptoms can vary between both men and women, but one common symptom in both is that they will both experience a decreased libido and loss of sexual drive. In men, you'd experience this as erectile dysfunction or sexual dysfunction, and in more severe cases may experience infertility and gynecomastia. In women, you'd expect to see galactorrhea, so this is spontaneous production of breast milk, and this is at times where you'd normally not expect breast milk to be produced. They may also note disruptions of normal menstrual periods, such as amenorrhea, as well as breast pain or difficulty or painful intercourse. In terms of the causes behind hyperprolactinemia, it's important to recognise that they are physiological and pathological causes. So the physiological causes include those such as pregnancy and breastfeeding, whilst the pathological causes include pituitary adenomas, so prolactinoma, or compression of a pituitary stalk, which may occur due to surrounding structures compressing the pituitary or due to direct injury. Medications and herbal medications can also cause hyperprolactinemia, such as dopamine receptor blockers and opiates. What's really important about this is the pathophysiology behind it. So hyperprolactinemia, so too high levels of prolactin, inhibit the secretion of gonadotropin releasing hormone from the hypothalamus. The hypothalamus normally sends a signal to the anterior pituitary to release FSH and LH. However, in the case of high levels of prolactin, this does not happen, and we see reduced levels of FSH and LH. And this is what can lead to the symptoms experienced above, as we've talked about, but also can lead to male and female hypogonadism, and we'll talk a little bit more about this later on. Diabetes insipidus is next, and it's really important that we differentiate this from diabetes mellitus of any kind. So diabetes insipidus is marked by polyuria and polydipsia, so too much urine and too much thirst. So that's very much linked to the symptoms. We see frequent urination as well as polyuria, and we see increased thirst as well, which can often lead to dehydration due to increased osmolarity of the blood. So when we see dehydration in diabetes insipidus, this is fairly common. This may present in a variety of ways. In more severe cases, you may see cracked skin, confusion, dizziness, loss of consciousness, but very commonly people will just be a little bit dizzy and fatigued. There are 4 types of diabetes insipidus to be aware of. So we have neurogenic or central diabetes insipidus, and this is a problem that's coming from the hypothalamus, leading to less ADH being produced. And as a result, if we have less ADH, causing less aquaporins in the collecting duct, less water is reabsorbed into the body, and therefore more urine is excreted, and it's dilute urine because we're producing so much of it. There are other types of diabetes insipidus, including nephrogenic, gestational and dipsogenic, but neurogenic or central is the main type to be aware of. It's the most common cause of diabetes insipidus. And it's important to be aware of the management and treatment as well. So desmopressin is really important because it's synonymous with the actions of ADH in the body, i.e. opens up those aquaporins on the collecting duct and allows reabsorption of water into the body. Next, we're going to talk about XY dysgenesis. So this is also called Sweyer syndrome. It's a type of hypogonadism. So what we're going to talk about next are both male and female hypogonadism. So in XY dysgenesis, we see a patient whose karyotype is 46XY. So in terms of, if we look at this patient, we will see a female patient with streaked gonads. So we won't be able to see the streaked gonads, but we see a female, normal female patient. If it's left untreated at this stage, which it often is, the patient will not experience puberty, and they won't know they've got XY dysgenesis normally until this point, because they notice they don't have puberty, they present to the doctors, and as a result we do testing, we do this diagnostic testing, and we eventually find out that the karyotype is XY, which is of course male, and not XX, despite the appearance of a female. The complications and consequences of this are of course that the patient may not be able to have children, because of course if we have those streaked gonads instead of actually having ovaries, we have no eggs, and therefore as a result its inability to conceive. There's also noticed an increased risk of cancer with streaked gonads, particularly a gonadoblastoma. Several research papers have shown that this is possible. There's also an absence of breast due to a lack of estrogen, and unpredictable menstrual periods due to a lack of progesterone. So this all links into the kind of things the patient will notice and therefore present to the doctors with. A little bit of pathophysiology behind this, so please be aware of the SRY gene, its cause and how it leads to development of a male fetus, and also its role in XY dysgenesis and how a female is actually produced despite these streaked gonads and actually having a male karyotype. So now to talk a little bit about male and female hypogonadism. So male hypogonadism essentially means that the testes aren't producing enough of the testosterone that it should be producing. Now it can be primary or secondary, so a primary problem originates from a problem within the testes themselves, and a secondary problem comes from higher up, like anything. So a secondary problem comes from higher up, like the hypothalamus or the pituitary gland. So in which case it would be a problem where we're not producing enough gonadotropin releasing hormone, or not enough FSH and LH being produced. So normally your LH stimulates the testes to produce the testosterone. So this problem can either originate from the testes themselves, which is a primary problem, or from higher up like the pituitary or the hypothalamus, which is a secondary problem. Common causes of primary hypogonadism, so things that go wrong exactly with the testes, are Klinefelter syndrome, so where you have XXY as your karyotype. Cryptorchidism, so undescended testes at birth, have a link to reduced levels of testosterone in childhood. We have mumps orchitis, so this is inflammation or infection which can cause damage to the testes. Hemochromatosis, injury to the testes directly, and previous cancer treatment can also cause hypogonadism. There are secondary causes. These include Kalman syndrome, pituitary disorders, and inflammatory disorders, basically anything that can affect higher up and affect the pituitary or the hypothalamus. And lastly, if we just talk about female hypogonadism as well, so hypogonadism in females occurs again with little or no production of sex hormones, and in females of course the gonads are the ovaries, and we're not producing enough of the estrogen and progesterone that we should be producing. So primary causes, again we're thinking about problems with the gonads themselves, so autoimmune disorders, genetic disorders, severe infections, and higher up causes, secondary causes, these can be again Kalman syndrome, infections such as HIV and AIDS, pituitary disorders and inflammatory diseases. The secondary causes are fairly similar for both male and female hypogonadism. It can lead to lack of menstruation, slow or abnormal breast growth, hot flushes and loss of body hair, and it's important to be aware of the normal levels of estrogen and progesterone as well, because then you can say, well, if these are absent, what kind of symptoms is the patient going to suffer with? That's everything for this video. Thank you for listening, and I hope you found it useful.